Hello. Can anyone hear me? Okay. Hi, everyone. Sorry, I've had some technical difficulties. I hope you guys can all hear me now. I hope you're having a good evening. My name is Joelle. I'm one of the F1s currently in the Northwest. I'm also the Obs and Gynae lead for Mind the Bleep. Hello. Yes, this is recorded. So today we're going to cover high-yield UKMLA topics for the gynecological disorders. I'll try to answer all of your questions, but if I can't, I'm sorry in advance. If you guys need anything, you guys can just cut me off at any point. I'll get started. This is a general overview of gyne disorders. Of course, you'll need more in-depth learning and practice, but I hope it's a good general overview. So this is the content we're going to be talking about today, focusing on endometriosis because it's a really high-yield topic for UKMLA. We'll discuss as well adenomyosis, fibrosis, abnormal uterine bleedings, amenorrhea and ovulation, PCOS, a little bit on PID, menopause, and hormone replacement therapies. So let's get into it. I apologize for the slightly graphic picture. Endometriosis always comes up in gyne exams. It's a very high yield topic, and I think we should really focus on it as much as we can. So endometriosis is very common. It affects about 10% of the population. I think it does affect more than that, but it's very underdiagnosed. It takes about 7 years on average for a woman to get diagnosed from the onset of symptoms, which is crazy. You would know at least one woman with endometriosis in your life. That's a guarantee. So what is endometriosis? It's endometrial-like tissues outside of the uterus. It affects, as I said, 10% of the population of women. We don't have a clear etiology of it yet. Some people say it might be retrograde menstruation, meaning endometrial cells going back from the fallopian tubes and out to the peritoneum and then just sticking everywhere. There's a lot of, shall we say, sorry, apologies. Hypotheses. A lot of these etiologies have been rejected and proven to be untrue. We have also choriomic metaplasia, which is that the cells of the lining of anything can transform and become endometrial cells, but that's also, again, a hypothesis. It's what we know for sure is that it's associated with menstruation and that hormonal changes cause the bleeding, chronic inflammation. And because these are endometrial-like tissues, they act, again, as endometrial cells. So when the woman has menstrual bleeding, they bleed as well. So you'd expect very, very bad symptoms. It's also estrogen dependent, as you may know. So endometriosis can be classified into 3 different, let's say, categories. We have peritoneals, so which are on the peritoneum wall itself, just endometrial tissues. They look kind of blackish, tarry on the cells, or on the peritoneum from the inside. They can also be ovarian, so you can have endometriomas or ovarian cysts that are also called chocolate cysts, and more deeply infiltrating endometriosis, and that could be literally anywhere. Some cases you can see on the bowels, appendix. Sometimes it can mimic appendicitis. Sometimes it can be found on the lungs. Sometimes, very rarely though, it can be on the nose, pleural cavity, pouch of Douglas, etc., etc. It's been named one of the top 50 most common chronic painful conditions as per the NHS. So that's cool. It's important to know what location, size, and depth of infiltration endometriosis goes to, but it's also important to know that some people may have very superficial but very painful endometriosis, and others can have very deep, very asymptomatic endometriosis. So the location and depth do not really determine the pain severity. So the risk factors, again, estrogen dependent. So anything that increases your estrogen, so early menarche, late menopause, all of the other things. The signs and symptoms mostly vary based on the location. So let's say they start as dysmenorrhea. It could be cyclical, but then it can become more and more progressive and become constant. And that's because endometriosis causes inflammation locally and therefore adhesions in scar tissues, and that can cause chronic pain. You can also have dyspareunia, which is one of the most common, let's say, clues when it comes to exams and the way exams are worded. So you'd have deep dysmenorrhea, deep dyspareunia. You can also have, again, cyclical or chronic pain, and it does cause infertility, especially when it affects the ovaries. You can also have painful defecation if it does affect the bowels. If it does affect the bladder, then you'd have hematuria, which would be very, let's say, interesting, because you'd only bleed when you pee when you have a period. Very, very niche. You don't have a lot of things that could cause that. You could also have IBS-like symptoms. Rarely, if you do have endometriosis on your lungs, it can cause something called catamenial pneumothorax, but that's very rare. And sometimes, as I said before, it can be completely asymptomatic. What you do need to know is there is nothing more important than a laparoscopy, and it's the only gold standard diagnosis for endometriosis. But not everybody does get a laparoscopy. A lot of people just get treated based on a suspicion of endometriosis. And sometimes you have to bear in mind that accessing the, let's say, peritoneum or excising the lesions would cause more and more adhesions as well. So you'd have to think pros versus cons when it comes to that. Sometimes, especially when you have ovarian endometriosis, you can see that on a ultrasound, so transvaginal or just a regular ultrasound, but not seeing it does not exclude endometriosis. So that's very important to know. On examination, most of the time it's going to be normal, but you can have some tenderness or maybe feel some nodules or some masses like like a very large endometrioma. Again, very rare. CA125 has been shown to be elevated in endometriosis, but not having an elevated CA125 doesn't exclude endometriosis either. So that's good to know. So when it comes to the management, a lot of people have previously mentioned to me that gynecological disorders are a little bit confusing when it comes to management, because we don't know when Mirena is used first, when hormones are used first, and it's a little bit confusing. So we're going to try to break it down. When it comes to endometriosis, it's important to know that the uterus itself is not the problem. So the Mirena is not the first line you'd use. Sometimes they do like to trick us in UKMLA questions, and the answer would be just paracetamol as a first line. Obviously, paracetamol is the first line. We do know that, but aside from paracetamol and NSAIDs, we can have other managements. So if you do suspect endometriosis, you can start by treating it. How do we treat that? We start with some medical management. So the goal of that would be suppressing the pain. It does not reduce the recurrence or the size. It only masks the symptoms. And it works by just inducing like a pseudo-pregnancy or pseudo-menopausal state, because, well, they won't be receptive to estrogen as when you don't have a suppression of sorts, if that makes sense. So we can start by COCPs, POPs, GnRH agonists, etc. So about 80% of women do find this medical management effective. Not always, though. So we do have to resort to other stuff, like, for example, the Mirena. Mirena has been shown to be useful when it comes to post-laparoscopy. So after diagnosis, after excision, a lot of people choose to have their Mirena inserted because it helps prevent recurrence, or so it's so the new research says. Still very up in the air, still very um, well under researched topic in my opinion. So if a woman does come and say, I want to conceive, then obviously the first two options are not going to be on the table. So you'd have to resort to some more elaborate kind of management, and you'd need to refer to a gynecologist or specifically an endometriosis specialist gynecologist. They could try something called danazol, but for the purposes of UKMLA, we'd go for surgery. So based on where the location is, we try to excise these lesions. If they are on the ovaries, then you'd try to go for a cystectomy, so just removing the cyst while trying to preserve as much as you can the ovarian tissues. Sometimes you may need to do something called adhesiolysis, which is just breaking down the adhesions. And in very severe cases, you might need to remove everything altogether. Now, do you think that endometriosis, do you think that hysterectomy is a cure for endometriosis? What do we think? So someone asked if pain medication are an answer, would that be considered first choice? Yes, of course. If you have a person with some mild symptoms, mostly around their periods, and they would tell you paracetamol and NSAIDs are enough for me, then yes, that would be first choice, definitely. Most people do not feel that way though, and especially because it could be progressive. So most of the time we'd stop at medical management. I would say a lot of people just go on the pill to suppress the symptoms. That's not ideal, obviously. It, as I said before, only masks the symptoms. But if it works, that's the guidelines for now. Um, yes, a hysterectomy might not solve the issue, and that is because the uterus itself is not the problem, as we mentioned before. You could have the scars anywhere. You could have the tissue lining anywhere in your body, causing any sort of symptoms. Now, if a woman does need hysterectomy, then it can be done laparoscopically as well as excising the endometriosis, if that makes sense. So if she has a need for a hysterectomy for other purposes, let's say large fibroids or cancers, anything of the sorts, then yes, we can remove it. And a lot of people after menopause and hysterectomy, because of the decrease of estrogen, it would help their symptoms. So the endometrial tissue or the deposits would not react to estrogen anymore because we've had that surgery. So in some ways it is helpful, but it's not curative. Does that make sense? I hope it does. Any questions? Okay. So what you really need to focus on is how endometriosis presents in the questions, what kind of clues they're giving us when it comes to symptoms, and just try to see whether the woman's looking for conceiving or not, and just go by systematically, basically. Have you tried paracetamol and NSAIDs? Yes, and it doesn't work. Okay, let's go for medical. If medical doesn't work, we'll try surgical then. Yeah, and complications of endometriosis again depends on the locations of the endometrial tissues. A lot of time, because of the adhesions, you could have a lot of problems. You can have it as bad as sometimes needing a stoma bag for their bowels because of how severe their endometrial tissue is on their bowels, let's say. Some people may need catheters because they have extensive endometriosis in their bladders. Sometimes you may have, again, as we said before, pneumothorax. Some people may have chronic appendicitis that would be excruciating in pain, but would not be technically appendicitis, and therefore it could go unnoticed for a very long time. And there's some new research saying that it could increase the risk of IBD. Now, bowel obstruction would make sense because of adhesions, but yeah. And if you do have some adhesions around the tubes, then that would also increase your risk of ectopic pregnancies. So while endometriosis itself may not be fatal or severe, it does cause a lot of complications, and that's something we should always keep in mind. So I hope that was a nice recap of endometriosis. I'll move on to adenomyosis, which is the little brother of endometriosis. It's endo, but confined to the uterus, mostly in the myometrium. Again, I apologize for the graphic pictures. This is a very representative, let's say, picture of what adenomyosis feels like. It's, well, endometrial tissues inside of the myometrium causing inflammation again. It's not where it's supposed to be, basically. So it causes contractions, it causes deep pain, it causes, because of the inflammation, you'd have an enlarged and boggy uterus. And those two words are very, very common when it comes to stems, question stems on PathMed or on the UKMLA. You'd always see enlarged and boggy uterus for adenomyosis, and that should be a clue. So it causes menorrhagia, obviously because of the tissues, very deep pain, chronic pelvic pain, and pain after intercourse or during intercourse. So it's more common in multiparous women at the end of their reproductive years. So typically you'd have a 40-ish-year-old woman with these kinds of pains. But the good thing is adenomyosis can be diagnosed via ultrasound. Most of the time it can be seen, unlike endometriosis. And as I mentioned before, because adenomyosis is a uterus problem, then Mirena here can be used as a first-line option. So for your exams, you should always make sure to read whether the woman wants contraception or not, and whether she wants children or not, because that would guide you. If they say, actually, we're trying to conceive, then Mirena would not be the proper choice. And they'd always try to trick us like that, at least from all the UKMLA previouses I've done. So pay attention on what the question says, pay attention on, what they're asking, basically what the woman wants out of the management. If they don't want any hormones, then you can go for tranexamic acid, which is just, it's there for, reducing the bleeds. So it does help quite a lot with the menorrhagia. You can try NSAIDs like mefenamic acid instead. You can go for hormonals, so COCPs, POPs again. But usually Mirena is the first line when it comes to hormonal treatments. And if they've tried everything and everything else failed, and they don't want to conceive anymore, then obviously we can go for a hysterectomy or an endometrial ablation, because that would also mean no more pregnancies. Any questions about adenomyosis? Adeno itself is not life-threatening. It's just affecting the quality of life mostly, I would say. So you should always consider that when it comes to DDXs of gynecological disorders. And in this case, hysterectomy would be curative, unlike endometriosis. Okay, so moving on to another very common disorder, fibroids and leiomyomas. So these are benign tumors, proliferations of smooth muscle cells and fibroblasts. It also usually comes about ages of 30 to 50. And it's one of the most common benign uterine tumors in reproductive age. You'd see that very, very, very commonly amongst women of this bracket of age, let's say. And typically, these are also hormonally receptive. So after menopause, they do tend to regress on their own, which is also important when it comes to management, because if you do have a slightly biggish fibroid, but the woman is almost near the stage of menopause, then you could watch and wait and just let it regress on its own without having to treat it. So you have 3 types of fibroids, and that's very important to remember, because they could affect the signs and symptoms that the woman presents with. So you could have subserosal fibroids, which are usually near the outer surface of the uterus. They can extend to the peritoneal cavity and therefore cause pressure-like symptoms. So they could put pressure on the bladder, put pressure on the bowels, that sort of thing, and therefore cause symptoms. It could also be intramural, mostly causing menorrhagia and dysmenorrhea. And they could also be submucosal, so in the inner lining of the cavity, which I guess would be bad when a woman would be trying to conceive, because, well, it reduces the size of the volume of the available uterus. Plus, sometimes they can twist on each other and cause torsions. So those are the three main types of fibroids. Sometimes they can be asymptomatic if they're small, and other times, just as we mentioned before, we can have infertility, menorrhagia, dysmenorrhea, etc. And in comparison to adenomyosis, this is not a boggy uterus. This is rather an irregularly enlarged uterus because, well, you have the fibroids on different areas of the uterus itself. So it's not like a smooth enlargement. It's just a bumpy. This is a picture of one of the fibroids I saw myself. It's very cute. It's, well, cool, let's say. So we have a lot of treatments for fibroids, and fibroids are diagnosed by ultrasound most of the time. Sometimes you can diagnose it via hysteroscopies. Abdominal and bimanual exams would be relatively helpful, not so much in real life. So the treatments, as I said before, if it's asymptomatic, just watch it, safety net, don't touch it, basically. Because it's a uterus disorder, then you'd go for a Mirena first, as long as you don't have a distortion of the cavity. That's very, very important. You cannot use Mirena coil if you have a distortion of any kind. So bear that in mind, just don't forget it. Mefenamic and tranexamic acids are very important. Hormonal treatments can also be used. You can also have some sort of benefit to GnRH agonists because they've been shown to reduce the size of the fibroids within like 3 months. About 50% of the size would be shrunk, but once you stop the GnRH agonist, then they just grow back. So not very useful. And yeah, surgery, obviously. We can either have a myomectomy, so just the removal of the fibroid itself, or uterine artery embolization, or just a hysterectomy altogether. And as I said before, depending on the compressions of the adjacent structures, then you'd have different symptoms. Sometimes you can have subfertility and infertility. And if you do have some fibroids and you do get pregnant, then you'd have some higher increased risk of miscarriage, fibroid vascular infarction, which is what I said before about the twisting of the fibroids, causing acute pain, sometimes some bleeding, fetal malpresentation. So they could be breached because they don't have enough space to turn, preterm labor, etc. So usually we do not interfere when a woman is pregnant and does have some fibroids, because it's just more risk than just leaving it alone and observing. I think that's it for fibroids. It's pretty easy. Those three come very, very often in UKMLA gyne topics. Are we good so far? I'll take that as a yes. So abnormal uterine bleeding, this is a broad term. It used to be called dysfunctional uterine bleeding. It's, well, an abnormal bleeding in absence of pregnancy or genital tract pathologies, or basically any cause that we know. We would call that abnormal uterine bleeding. And that would be heavy menstrual bleeding is the most common symptom. A lot of people with heavy menstrual bleeding do not have a definitive diagnosis of what the underlying cause is, and they would fall into that category. So you have to rule out any other diagnosis first. So most importantly, pregnancy. and then other bleeding problems, so von Willebrand or any sort of disorder that could cause you to bleed more, hypothyroid, hyperthyroid, fibroids, PID, PCOS, endo and adeno, as we discussed before. So you'd look for everything before saying it's an AUB. And the treatment is more or less the same. So we'd start with non-hormonals, we'd start with pain relief, and then we go to tranexamic acid for trying to reduce the menorrhagia, mefenamic for the pain. If that doesn't help, we'd go for hormonal. Usually because it's a uterus problem, you can go for Mirena first. And hormonal is provided that the woman is okay with her having a contraceptive on. So provided she's not willing to conceive anytime soon. And the surgical, which is the hysterectomy, which is obviously curative. I do have some, this is a nice picture of all the causes, let's say, of abnormal uterine bleeding based on the FIGO classification. So it could be read as palm coin. I don't know if you guys have heard of this before. P stands for polyps, A for adenomyosis, L for leiomyoma or fibroids, M is for malignancies, so any kind of cancer, uterine cancer mostly. C is for coagulopathy, so any bleeding disorders. O is for ovarian dysfunction, E endometrium, I iatrogenic, so for example inserting a Mirena coil, and N is otherwise unclassified. Usually endometrial ablation is what people go for surgical as a surgical intervention because they do have a lot of improvement without having to undergo a massive surgery like a hysterectomy. So that could also be an option. But for the sake of the UKMLA, you should just focus on the first two, so non-hormonal and hormonal. AUB does not come that often, but it's good to have it as a kind of DDX, and after you rule out everything, you should think about AUB. And that's it for that. So why is Mirena so important? Before the discovery of Mirena, what people resorted a lot to surgeries, but because of that miraculous invention, let's say, a lot of people don't need surgery anymore. It's very effective. It has been proven to help a lot with menorrhagia. So it's usually recommended as a first-line option when it comes to uterine bleedings in general, so adenomyosis and fibroids and AUB, and that's why it's always so prescribed, let's say, or it's always a buzzword, let's say, when it comes to gynecological disorders. And I would say the only time it's not a first line is when it's not a uterus problem. So again, endometriosis. Otherwise, you do use Mirena quite a lot. So on this slide, you can see a reduction of over a 12-month period for all of these methods. Although, it's not very accurate, but I tried my best. So Mirena is the most, let's say, efficacious, which is why it's always used first line. Moving on. So I'm going to talk a little bit about amenorrhea before I move on to PCOS, just because it's important to know that there are other causes. You can have a primary cause of amenorrhea and a secondary cause. Primary is before kind of age. So when you don't have any periods by the age of 15 or 13, but with no sexual characteristics, secondary sexual characteristics. So like hair growth and breast augmentation, stuff like that. And that would mostly be either genetic, like Turner's, congenital adrenal hyperplasia. You should always think of imperfect hymen. For some reason, it's common, and it's, well, not that big of a deal. It's very easily fixable. Congenital malformations and functional hypothalamic amenorrhea. So very thin, very athletic, young teenagers would fall into that category as well. You also have secondary, so you'd have periods and then you stop having them for some reason for about 3 to 6 months, or just 6 to 12 months of previous oligomania with previous, let's say, on and off periods. And PCOS would fall into that. as well as premature ovarian failure, thyroid problems, Sheehan problem. Do you know what Sheehan is? Does anyone know what Sheehan is? I think it's a hot topic on PassMed, but it doesn't really come, let's say, in the exams. After birth, you'd have a pituitary infarct, and that would cause something called Sheehan syndrome. You'd also have Asherman syndrome under that category, which is just uterine adhesions. And always, always, always exclude pregnancy before saying the patient's amenorrheic. So a good rule of thumb is usually gonadotropins. If they're low, then it's a hypothalamic cause. If they're high, then it's usually a primary ovarian failure or like an ovarian cause. And for investigations, you can always try covering all your bases and go for thyroid, prolactin, ultrasounds, FSH and LH, estradiol, testosterones. And then the treatment of amenorrhea is based on whatever the cause is, if that makes sense. So I've put a nice table here, took it from somewhere, and I think it just encompasses a lot of important diagnoses of secondary amenorrheas. What we're going to focus on today is PCOS mostly, but you can have a look what other causes of amenorrhea would look like. I'll go to PCOS then. No, not yet. We'll talk about anovulation first, which is just before the PCOS, let's say. So what is anovulation? It's when you have menstrual cycles but without any release of eggs. So you could still have bleeding or menstruation per se, but you don't have any progestin secretion from the corpus luteum after the ovulation because you don't have it in ovulation, and therefore you'd have a persistent endometrium. Sometimes it does shed and cause like menorrhagia kind of, or oligomenorrhea, periods on and off, unstable. So, but it's really unstable, and you're prone to heavy or irregular bleedings. Infertility is a very common symptom, obviously. And we have classifications of anovulatory cycles. So you could be in group 1, group 2, or group 3. One would be a hypothalamic cause. So you'd have a problem with the pituitary. So it's the higher, let's say, kind of the chain. Group 2 would be the hypothalamic pituitary ovarian dysfunction, and that's where PCOS would fall, and that's the most common cause of anovulation. And then you'd have the group 3, which is the lowest of the chain, ovarian stuff. So like ovarian failure, primary ovarian failure. We're going to focus on group 2 today, so PCOS, because it's around 80% of the most common stuff, or causes of anovulatory cycles. Ovarian failure does come sometimes well, not very often, but it does come. So bear in mind that ovarian failure is an important DDX when you have a woman with menopausal symptoms, less than 40-year-old, with no clear reason, or sometimes post-chemo for any other cancers. They would have a very raised FSH and low estradiol, so you treat it just as you treat menopause, which we'll discuss in a bit. And let's move on to, so the primary ovarian failure causes, you'd have premature ovarian failure, Turner's, autoimmune disorders, or sometimes even medication, so anti-epileptics, antipsychotics, chemo. And then you'd have the secondary hormonal disturbances, so anything like contraceptives, pregnancy, hyperprolactinoma, PCOS. So I think we should focus on PCOS today because that's the most common topic, let's say, in anovulation. I'm sorry for the very bulky slide. I tried to cover as much of the pathophys of PCOS as possible. It's a very tricky and intricate pathophysiology, but it's a very common endocrine disorder in women and therefore very important. So 80% of all anovulatory subfertility, as we mentioned before, the root of all the, let's say, problems in PCOS is not really clear, because everything interferes with each other. But the most common, let's say, clue that we have is hyperinsulinemia. So because of the high insulin that we have, you'd have a reduced sex hormone binding globulin, or SHBG, produced by the liver, which itself increases the unbound active testosterone. And the free testosterone itself is one of the key factors of the symptom, let's say, presentations. It's a very vicious cycle because, as I said before, the insulin resistance itself causes weight gain and excess body fat, which in turn would cause increased insulin secretion and therefore worsening the PCOS. And the insulin itself modulates the GnRH, which would cause an increase in LH. The increase of LH to FSH ratio is very, very important in here because the increased LH pulse and frequency from the pituitary, is not working properly, and therefore the ovaries prefer synthesizing androgen rather than estrogen when you have such, let's say, hostile environments. And obviously, the increase in androgen would stop the follicular developments and therefore cause anovulations. So you'd still have some increased estrogen, and that's because the follicular development stops before the maturation of the ovulatory cycle, and there will be no ovulation, but estrogen production may continue. So it's very tricky, and what you basically need to know is the three things that are hyperinsulinemia, raised LH to FSH ratio, and increase in androgen production. And those are the three pillars, let's say, of PCOS. I know it's not a gynecological disorder per se, but it does affect the way, it causes oligomenorrhea, amenorrhea, sometimes maybe increased vaginal bleeding, menorrhagias, which is why it has to be in our DDXs today. And it's very important to know Rotterdam criterias for the investigations and diagnoses. That does come quite often. And you need at least two of the following criteria on the left. So either irregular or absent ovulations, or you'd have clinical or biochemical. You don't have to have both. You can have either or of hyperandrogenism. So anything that leads to you thinking, okay, maybe this woman has high androgen. So could be clinical, like acne, hirsutism, or could be just an increase in total testosterone or a low sex hormone binding globulin. And the third criteria would be polycystic ovaries on ultrasound, so more than 12 antral follicles or an ovary volume of more than 10. Now, it's very important to know that PCOS itself can be diagnosed without having polycystic ovaries, but the fact that you have a polycystic ovary does not mean you have a diagnosis of PCOS. Sometimes, for some reason, you can just have an ultrasound and find some follicles and say, oh, you have a lot of follicles, but that doesn't mean you do have the PCOS, this like syndrome. You can have PCO, which is different. So it's important to have two or more of the criteria as per the NICE guidelines. And the management, you'd start with conservative management. You'd start with something like lifestyle advice, weight loss. If that doesn't work, we can consider COCPs. So cosiprendiol is used a lot. You can have it as cyclical POPs, for example, or a Mirena that does help manage the symptoms. Metformin is used, especially to aid the woman lose weight, but it's used as an off-label use rather than an actual treatment itself. And then again, when it comes to gynecological disorders, you have to ask the woman, are you thinking about conceiving or are you thinking about contraception? Because that would also guide our management. So if in the STEM it says they don't mind waiting, then you can go for all of these we've discussed before. If they are trying to conceive, then we'd cover something else. We'd go for, obviously you'd refer to someone more senior, like gynecological specialists. They need endocrine input as well, but clomiphene is used, letrozole is used, GnRH is used. Sometimes in very severe cases or very extreme cases, when you've exhausted everything else, you can use ovarian drilling. And if everything else fails, then you'd go for IVF or assisted reproduction techniques, any kind of technique. So PCOS is very, very complex endocrinological disorder, but it's relevant. And I think this is what you need to know mostly. Any questions about PCOS? Nope. Okay. So I'll move on to pelvic inflammatory disease. So PID is also not really a gynecological issue, but it's more of a sexual and infectious kind of cause. But it again presents as same things we've discussed before, which is why it's an important DDX to think of. So pelvic inflammatory disease almost always comes from an STI. Very rarely it could be because of a descending appendicitis. Very, very rarely. So it causes endometriosis, salpingitis, oophoritis, basically inflammation of the entire gynecological tract. It's more common in young people with early first sexual intercourse or with multiple sexual partners, people who have a history of STIs, etc. So the most common cause of PID is chlamydia by far. Neisseria is also one of the other common causes, but chlamydia is by far more common than Neisseria. And the symptoms would be something like fever, dysuria, a pelvic or a lower abdominal pain, deep dyspareunia as well, which again would make you think of other stuff. So like endometriosis and adenomyosis also cause dyspareunia, so be careful. In here you'd have more of an infective and inflammatory picture, fevers, especially abnormal vaginal discharges. Fitzhugh-Curtis is always, let's say, taught. It's not really that common. Don't think it comes that much in questions either, but it's something you have to let's say, remember. It does come with the pelvic inflammatory disease, and it's a complication of PID, let's say. So it's a right upper quadrant pain, and it's due to the adhesions of the anterior abdominal wall with the diaphragm and the liver capsule. So they adhere with each other and causes sort of hepatitis picture. You can also have adrenal tenderness adnexal tenderness because of the inflammation around that area, and infertility, as well as increased risk of ectopic pregnancy because of the salpingitis. So you'd have more adhesions around that area, making it more likely for you to have ectopic pregnancies. So for PID, always exclude a pregnancy before looking for anything, before treating anything. Again, this is very important. We'd go for vaginal swabs and regular blood tests, and then you'd screen for all the kind of infections, especially HIV and syphilis, because if you do find an STI, then you're likely to find other STIs. You'd go for an ultrasound. That's the most accurate way to diagnose PID. You'd also be able to see any hydrosalpinx or abscesses, so that's very important. But the gold standard, obviously, is laparoscopy. It's not really routinely done in reality, since the treatment is more or less antibiotics. There's not much of a need for a surgical intervention, so they wouldn't go for that unless it's called for, let's say. The treatment would be obviously pain relief. If they do have any IUDs, IUSs, they have to be removed because they would harbor more of the infections and the bacteria. So those have to be removed. If they're septic, obviously they'd need admission. And then you'd start treatment until you find the results of the swabs. So usually, according to the guidelines, we start with this kind of empirical treatment. And the rationale behind the first line is that ceftriaxone covers for gonorrhea, doxycycline covers for chlamydia, and metronidazole covers for bacterial vaginosis. So those are the three main antibiotics we'd give. So the ceftriaxone is just one single dose, and then the rest is for 14 days, doxy and metronidazole. Obviously, we have some other variations. So ofloxacin can also be used with metronidazole, or if they do have mycoplasma, then you'd use moxifloxacin. But those would be usually much more niche. So always use first line as a first, let's say, go-to. Yeah. So always also give advice. So safety net, make sure they're safe for later, make sure they use contraception. Meanwhile, as you know, they're highly unsuitable for a pregnancy at this stage because of all the infections and the inflammation and the adhesions, blah, blah, blah. If they do have HIV, then you'd need to refer them to a clinic, HIV clinic. If they do have an abscess, that may need draining, and you may need to contact trace depending on what notifiable versus not notifiable diseases they have. Not all of them do need a test of cure, but some may need the test of cures. We're not going to go into that. It's not that, let's say, relevant for UKMLAs. Is that so far fine? Any questions? Nope. Okay. I'll move on to discuss menopause. I'm not gonna go too much into menopause. It's fairly straightforward. So loss of menstruation after about 12 months of amenorrhea. If they're less than 50, then that would be 2 years of amenorrhea. The mean age of menopause is 51, and you'd have these hot flashes, unpredictable periods that go and come back, dry skin, night sweats, vaginitis, all of these things. It could affect your sexual function, it could affect cognition, joint pain, osteoporosis. So it's a multitude of symptoms all across the body. It could be very debilitating when it comes to quality of life. And so we do try to help as much as possible. And while you do have high FSH, this is not routinely done, at least not in the UK. It's more of a retrograde diagnosis, let's say. So you just wait for a year and then you say, well, this is the diagnosis, it's done. The management, you'd go for lifestyle changes first, try to help as much as possible. And I've listed them all here. We all know them. And it's important to know that because you don't have that production of estrogen, you do have to consider the risk of cardiovascular diseases. So you have to assess for that and manage as necessary. Osteoporosis is also common, so we do need to prevent, and that is usually done by giving them some calcium, safety net, all of these things. You'd also have to screen for cancers. And you do need contraception, even though they have menopause, for at least 2 years after their last menstrual period if they're less than 50, or for at least a year if they're more than 50, and that's until 55. And when I mean contraception, I don't mean HRT. HRT is not contraception. HRT is hormone replacement, and that's very, very different. So if the woman is still sexually active at the age of, let's say, 50, then she would need HRT and progesterone pills. Don't forget that. Non-HRT treatment would be also dependent on what kind of symptoms they have. So if it's mostly psychological, they can go for CBTs, SRIs, SNRIs. If it's mostly vaginal dryness, they could go for creams, vaginal estrogen creams. So basically, whatever the issue is, you try to address that. And what I really wanted to discuss here is HRT. I feel like HRT is a very important topic. Sounds difficult, but actually isn't. So why would we use HRT? First, HRT can be used transdermally, orally, topically. We do have a lot of options for HRT. And as a general rule, if a woman does have a uterus, then you need to add a progesterone. If they don't have a uterus, then you can just give them estrogen. And the rationale behind it is, can anyone say why? So usually the main concern in HRT, yes, exactly. The main concern in HRT is progesterone. So you do want to use it as least as possible, but you also do need it when they do have a uterus, because it again prevents endometrial hyperplasia. So you have to aim to prescribe the lowest dose of HRT for the shortest possible duration, because after all, everything has side effects. You start with, let's say, preparations, oral or transdermal, if it's mostly vasomotor or mood symptoms. If they do have urogenital symptoms, then you go for vaginal estrogen, and yeah, you consider the transdermal rather than the oral, because they have a better or less increased risk of VTEs. And then you should always aim to review the woman. So see how they've been doing on their HRT, make sure they don't have any new symptoms, any new bleedings, because obviously postmenopausal bleeding would make you think of more sinister causes. Um, Sometimes you can use progesterone as a local instead of oral, so the woman doesn't really have to take a oral progesterone. A Miranacol would suffice. That's the most safe, let's say, way of giving HRT, because that's what we're worried about mostly, right? Like the reason we're using a progesterone is because they have a uterus. We want to prevent hyperplasia. Mirana can solve that problem. So you can really get creative with HRT. And you have to consider the side effects, so nausea, breast tenderness, etc., etc. The benefits of HRT: they do decrease vasomotor and urogenital symptoms. They decrease the risk of osteoporosis because you're constantly giving the estrogen that they've lost. It prevents fragility fractures, and some research has found that it also decreases colorectal cancers. So the risks of HRT is increase in breast and ovarian cancer, especially endometrial if it's estrogen alone. It increases the risk of strokes, VTEs, coronary heart diseases, and it's contraindicated in women with breast cancer, either current or past, any estrogen sensitive cancers, and especially contraindicated in undiagnosed vaginal bleed, because you want to make sure it's not cancer or hyperplasia again. So for the duration of HRT, you can usually use it either cyclically or for perimenopausal women. So for women who do still have their periods, you can use it cyclically with let's say, bleed period, just so that you can regulate their periods better. That does help a lot with the symptoms. And if they're postmenopausal, then obviously they don't want any bleeds. They can't have any bleeds, so you'd use it continuously. And they can be continued up to 5 years. Stopping them gradually is the best. And as we said before, you should monitor for any sudden symptoms, any new symptoms, any bleedings that are abnormal. And always reassess their benefits, their risks, their needs. That should always be a continuous kind of discussion. So this is a nice diagram I stole from somewhere. It's a comparator, let's say, of how much HRT increases versus decreases the risks. And you can see here that it doesn't really make much of a difference. So this is what this shows is a difference in breast cancer incidence per 1,000 women aged between 50 to 59, and approximately the number of people that are diagnosed with breast cancer in addition due to having HRT, and that's very low, +4. So in comparison, an additional 24 women get diagnosed with breast cancer for being overweight or obese, so a BMI more than 30. So while it does increase the risk, I wouldn't say it's that significant. But yeah. So this is another one, just saying that the risk after 10 years would be 1 in 50 people have who take estrogen, progesterone daily, got cancer diagnosis. 1 in 70 for people with estrogen and intermittent progesterone, and 1 in 200 with estrogen only. So estrogen is very safe, and Mirana can be used instead. So there's that. And that's it for tonight. I hope I didn't bore you guys too much, and thank you. I would appreciate the feedback. I'll leave a few minutes for any questions that you guys may have. Okay. This is the link for anyone who wants to have a feedback done. No worries, thank you. You'll get certificates for attending, so thank you for attending, and keep a lookout for the next sessions. Thank you, everybody.